Okay, can you see my,
Yes, we see your screen.
okay. The first patient is first case is a patient in about age mid-50s who came in with some chronic shortness of breath and has this on her chest CT. We can see with lung windows here that she has extensive areas of consolidation.
Brent, we're just seeing your database screen, not your viewer screen. Does anyone see Brent's viewer screen?
No, I just see the data.
It's a new feature with GoToMeeting. You have to tell it which window you want to show.
Can you see it now?
Yes.
Good. Thank you.
Okay. Hopefully that'll work for the other cases there. Yeah, so you can see these large areas of consolidation throughout both lungs. You can see that there are air bronchograms in some of these areas of consolidation scrolling through. And so this was an outside institution. This was thought to be, pneumonia. You can see that it really doesn't look much like pneumonia. It has very sharp contours here, multiple areas, large areas called consolidation, some other small nodules here, and this is just a not any lymphadenopathy here, and this was just a case of primary pulmonary lymphoma. And I don't have the entire biopsy results of this, but this was the prelim is primary pulmonary lymphoma, and it has such sharp, nicely demarcated edges here and air bronchograms throughout the entire, consolidation here, and just a nice case of primary pulmonary lymphoma. And just thought that was a nice example.
Brent, how sick was that patient? Because I bet that's another clue that it's not a raging bacterial pneumonia.
Yeah, not sick, not very sick at all. So that would have been, the clue here. So it's just another good example of how you need to correlate with the history to see if they're appropriate for this this appearance. So this would not be. She did not have the appropriate history. Okay, and then this one was just a. Can you see this window?
Not yet.
Not yet. Keep
Wow,
going.
I guess you have to adjust it for each one then. Okay.
How we do?
So this is just a curiosity case. This is a patient with chronic renal failure, and as you're scrolling through, you can see areas of calcification within this chronically atelectatic lung with chronic pleural effusion, pleural thickening. You can see that along the left atrial wall there's also calcification, and also along the anterior wall of the left atrium and along the pulmonary arteries, or the interstitium around the pulmonary arteries here. So this was stable over a couple of years and was thought to be metastatic pulmonary calcification in the setting of chronic renal disease. So it's just a nice example of how when it becomes severe, it can go to multiple other places besides the places you kind of expect, like the lung. So has anyone seen, along the left atrium like this in the pulmonary arteries? I think there was another case, a couple of cases that were shown in this conference like this as well, but
No, not seen it like that.
Not like that, I don't think.
I just thought that was somewhat of a curiosity.
Yeah, it's interesting, and why it would track along the heart as well into the vessel wall.
Yeah. So, all right. So now for the good cases. This one, let me switch the screen so you can see this. Okay. All right. So this is a patient who had a transcatheter aortic valve implantation, and like some of the patients who do this, of course, there were some contraindications to entering via the femoral approach, and so this valve had to be placed in an alternative approach, and the surgeons here have gotten quite good at doing a transcaval approach. And so they go in the IVC and take a series of lassos and snares and poke into the descending aorta and then come up retrograde and then do the valve retrograde. And so one possible complication is that you'll get a persistent connection between the aorta and IVC, and they plug that connection during the surgery, after the procedure with a vascular plug. But one complication is you can get a persistent fistula, and this is a, here you can see that there is early opacification of the aorta at the same level as the IVC is the same level as the entry, and so this is a case of a persistent fistula after this transcaval approach, and you can see that you want to follow the contrast here, and there is some reflux of contrast through the renal veins, but not enough to explain this. So this is a persistent fistula. So in some of these cases, they've just done conservative kind of watch and wait approach to these. And this one, you know, this was recent case, so I'm not sure what they're going to do with this. But have you all been seeing many of these? We don't see a lot of these persistent fistulas.
If we can't go the transfemoral route, they tend to go in like with a mini thoracotomy here. Just go right to the cardiac apex.
Yeah, the surgeons here have done that. They've had a number, you know, say that they prefer that less because it's a more morbid procedure than this. And of course, a lot of them going through the ascending aorta through a mini thoracotomy, you know, through the ascending aorta. But the transapical approach, they don't prefer here at this point. So, okay, and then this one dramatic case, last case. This is a patient who came in with severe lower extremity, essentially purple lower extremities, blue lower extremimies. And I'll show you a couple of here. Oh, sorry, let me pull up the screen. Okay, so we have a non-contrast CT here, and I'll actually show you before I get to that. I'll show you in 2015. Here's a non-contrast CT, and we had this endograft here, this endostent here, and we had an infrarenal abdominal aortic aneurysm. And it's a endostent that we can see, it looks pretty good here. And you can see the ascending aorta doesn't look bad. I mean, the descending aorta doesn't look bad. Let me show you the on presentation R study. This is the new study. And you can see that scrolling down, something, you know, more acute here has happened. So we have this dissection flap displaced intimal calcification within the descending aorta that was different from what we saw before. Let me show you the full arterial series here. And you can see here that starting here, you can see this dissection that wasn't there on the prior. And you can see already the true lumen is starting to compress, and this alone would be alarming because this, you know, we've seen many cases of this cause bowel ischemia and organ damage in the abdomen. You can just barely see the true lumen there. And then what's more alarming is that as you go down, and you wonder, you know, it's covering the celiac, the SMA, so those are still opacified, but starting to get into this area of, you know, profound stent collapse. So the pre-existing endostent has almost completely collapsed, and the lumen is shrunken down to nothing. And the aneurysm, of course, is still there, but the stent limbs are occluded, and everything distal to that is occluded. So, you know, he went emergently to the OR to see what they could bypass here, and they did a series of AXFEM bypasses, and this was just in the last couple of days. So I haven't checked to see how he's doing today, but apparently the extremities were just completely purple and, you know, with ischemic extremities. But this is really the most dramatic case of stent collapse that I've seen. I don't know if anyone's seen a, you know, if anyone out there has seen a more dramatic case, but, you know, not quite sure. I think that he, probably the presence of the new dissection and then, you know, caused you know, I'm not quite sure how that affected the morphology of the stent, but it certainly collapsed. And this is one thing that you always hear about this as a risk, but this is a dramatic example.
So, Brent, is the pressure that high and outside the stent that it just crushes it, or is it?
I think one scenario is enlarging aneurysm causing pressure to build up and then stent collapse. And this aneurysm had increased in size, but not that dramatically. So I'm guessing it's some combination of the new dissection, the fluid dynamics there, and maybe because the true lumen, the pressure head was diminished because it's so compressed, it's so narrow there because of the new dissection. Maybe all those things had to played into this, but. Whatever the cause, it was, certainly a dramatic presentation. So, but that's all I have.
Great, thank you. Seth, are you there?
I'm here. Sorry, I had my thing on mute.
All right, are you ready to show cases?
Yeah, I'm good.
All right.
I don't know how. Can you? Let me know if you can't see my thing.
It looks good.
Okay. All right, good. This is an interesting case only because I had not seen this before, and therefore, if I can see something that is fascinating to me, I'd like to show it. So this is a person who kind of came in with a unknown history. She was thought to have some sort of mediastinal cyst, but also this weird abnormal ultrasound, which showed what looked like two aortas, and she had a dilated sinus. So you can kind of see here, this is a parasagittal view. We have an aorta, and then we have this other vessel that's mirroring the aorta. And what this is it's a hemiazygous continuation of the IVC. Unfortunately, we didn't go down super low, but there's no right-sided IVC at all. The only venous drainage she has is on her left side. Of course, she has a suprahepatic IVC because she needs that to live. And then this thing goes up and then comes across, and if I could show it in the thing, comes across and then drains into a left-sided superior vena cava. So here's this thing coming up and around, draining into a left-sided superior vena cava, dumping into the basically coronary sinus. So so this thing came around, the IC came around, made a loop, and then dumped down into the coronary sinus, which is not seen here, but we see it on not to waste anyone's time, I'll send all the images along where you can see it on the cines and the SSFPs. And then on top of that, so I had never seen, we see IVC continuation or azygous continuation not that infrequently, but to see a hemiazygous continuation is something we had just not seen before. And then on top of that, she has this mediastinal cyst, and I did a lot of stuff to confirm that it was not, and it was quite bright on T1. I did a lot of stuff to confirm as best as I could that it wasn't a vascular or lymphatic structure, and I'm not really sure what that is going to wind up being, but I'm guessing some sort of foregut duplication cyst. And of course, I don't know if there's any known association between, I don't know why it's not showing the one where you can see it really well. Anyways, I don't know if there's any known association between foregut duplication cysts and venous anomalies. And we did look, she doesn't have polysplenia. She doesn't have any other congenital anomalies. It's just a weird thing. Have people seen that before? I've not.
So
No.
I've seen one case in residency of a hemiazygous continuation, but it didn't have a left SVC. I'm actually trying to pull up the image now. That's an amazing case.
It's just weird. And I was really concerned that this thing was some sort of vascular weirdness sitting here, the cyst, but I could not see any flow in it. I did phase contrast through it. I did a bunch of stuff, and it's just a cyst. And it is subcarinal. It's probably just a simple foregut duplication cyst, but that was...
You wonder if it's somehow related to the hemiazygous continuation too.
The cyst?
Yeah.
Yeah, no, I'm saying that. I agree. I mean, there's clearly some sort of congenital embryonic sort of anomaly of budding of the venous system, and with that, I wouldn't be surprised if there's some sort of abnormal budding of the tracheobronchial tree that led to a bronchogenic cyst.
Can we see the carina? Can we see the carina?
Yeah, so here's the carina here. Everything is displaced a little bit to the right because of this left-sided SVC, and this thing is right. So here's the left main stem bronchus here. To the left, base of the left main stem bronchus is directly anterior to the midpoint of the thoracic spine, and this thing is straddling the subcarinal space.
Mm-hmm.
So it's a great location for it. But again, usually we see it midline or relatively midline. This one's more displaced, and I think it's because of the whole mediastinum is a little bit shifted over.
So the cases I've seen of hemiazygous continuation have crossed the mediastinum low down and joined the azygous vein.
Absolutely, absolutely. Yes, we have seen that, but and then the azygous vein is big. We have not seen one dump into a left-sided SVC.
So there's no azygous vein here either, right? Or is there?
Is there an azygous vein?
Yeah.
We did not see any sort of, we did not see any sort of venous structure really on the side. I mean, there was potentially something very, very small, and here's the azygous coming across, very small, and the whole right side. And so the reason she presented is she was having lower extremity. It's a young woman. She was having lower extremity swelling. And so we imagine that the hemiazygous drainage is probably not conducive to draining your lower extremities as well as having your normal anatomic IVC going right into your right atrium. And I assume that the pressures in the left-sided hemiazygous are probably a little higher than they would normally be, at least that in the IVC and right atrium, accounting for her swelling. And we did a ton of MRA studies and a ton of other stuff to show both the anomalies pretty well. It's just it's an interesting case, and this is not. Ooh, let me pull this up. Sorry, 1 second. I wanted to pull over this real quick. Hopefully, I don't have anything too personal on my email coming up. But I just wanted to do this real quick. Okay. So this is an older case. We haven't had the best cases recently, I have to say, and this is just a nice example of what you look for in a patient with hemochromatosis. So this is a patient where, in reality, you only need really one sequence to do assessment for iron deposition in the heart. You just need a multi-echo gradient echo sequence to assess the T2 star of myocardium. So even here, this is done and each one is done at a relatively steady interval, increasing milliseconds. I think this one's like 2.3, and the second one's 4.6, and the next one's 7.2. Anyways, you can even see on the earliest one, about 2.3 milliseconds, the liver's jet black, which tells you the patient clearly has, hepatic hemochromatosis, or iron deposition. But you can see that the myocardium off the bat usually appears very gray and very washed out. And as you get with a longer echo time, you get more dephasing of the T2 because of just inherent inhomogeneities of the field. But with iron deposition, that becomes accentuated. And you can see very early on how rapidly this thing drops out. And looking at it qualitatively, this sure does look positive. It's really nice. Our new software, we used to have to put all this stuff in by hand and draw the air. I'm not, I don't speak for Circle, but their software is great, and all you have to do is draw ROIs, and it does everything else automatically. And you can see that here the T2 star myocardium is 9.5. Liver, I was even having trouble getting it to spit out anything on the liver because the curve, I couldn't even get a curve. It was basically flat. And so basically they teach up to 16 and below is definitely abnormal. 16 to 20 is kind of a gray zone, and above 20 is normal. Some papers have differentiated from that by a millisecond or two, but that's a good number anyways. Below 16 is pretty abnormal, and this is 9.5. So just a nice case of hemochromatosis. I'll include the other stuff as well. And we just don't, and it's surprising. So in primary hemochromatosis, you tend, or secondary causes of iron deposition, you tend not to see cardiac involvement. It really does, in most instances, unless it really is those with primary iron abnormalities. This is an older case, just actually AML, who presented with this ugly-looking pericardial effusion, and I think people can see that there's very abnormal signal through the myocardium, and I will show the PET. There is a cardiac MRI as well, but for the sake of time, I'll just show the PET because the PET's more impressive. And you can see here, if I go the right way, that the heart is just completely infiltrated with what turned out on autopsy to be leukemic infiltration of the myocardium. And I still am confused about the difference between leukemic and lymphomatous infiltration. I have seen a fair amount of cases of secondary lymphoma. This is the first case I've seen of truly, I guess, leukemic infiltration, although if one happens, it's not surprising that the other one happens. And the MRI just shows a bunch of masses and stuff. It's impressive, but I think the PET is more impressive. And the last one, which will take way too long to load, is an old study, not a good study, but an old study showing an impressive atherosclerotic aneurysm of the RCA. That's about a 7 or 8 centimeter aneurysm that the patient underwent surgery for. And I was giving Charlie a little bit of sass, like I usually do, because how bad this study was in 2008, and you can see that there's definitely a dramatic improvement in the image quality we have these days. But you can see here, it's not a beautiful study, but there's this very large aneurysmal mass at the AV groove, and that turned out on cath and surgery to be a large RCA aneurysm, and there was flow in it. And that's it.
Okay, well, thank you. Those were really cool cases. All right, Howard?
Okay. Let me first just bring up, not that. We don't need to see the bad news today. I'm trying to see if I've got, here we go. Before I show you this particular case, I want to show you from my old teaching file. I'm trying to get the DICOMs for this, but I don't have them at the moment. But this is a patient that came in with severe acute mucositis, ulcerative mucositis of the trachea. So here we are in the subglottic trachea, and on this coronal reformation, we have these filling defects. And I will show you what it looks like on the VRT that I had at that time. So you can see the ulcerations here, what seem to be ulcerations and narrowing and mass-like structures. And on bronchoscopy, this looked, quite terrible. So this was direct bronchoscopy at the time, showing a tremendous, severe necrotic mucosa of the trachea in that particular person. So here I have a case of, in a young person, really unfortunate, of severe GPA. So on the chest radiograph, you can see multiple bilateral parenchymal opacities of different sizes, certainly consistent with that. And I will bring in the images of the airway, but just look how severely the airway is affected here, not so much with mural thickening, but what appears to be a tremendous mucosal, ulcerative, sloughing process involving the trachea, and of course we'll see some lung findings pretty typical of GPA as well. So this is, at least morphologically based on this, a severe tracheal involvement with GPA. And here again, at this point I don't know how much is secretion or mucus, but from what I see above, and as we scroll down, I think we have tremendous mucosal injury here again in the airways, so a very severe airway GPA as well as parenchymal as well. And here, even down here in the airways. And not surprisingly, over time, the reason I got to see this was that she has developed a stenosis of some airways. So more recently, she's had findings consistent with that. And here you can see that her left upper lobe bronchus is stenosed. I don't have a CT to go along with this with some volume loss, so severe airway involvement. And the sinuses just look terrible. So this poor young person has just terrible sinus disease from GPA as well. So a sinus, a terrible airway, and terrible parenchymal GPA with stenosis most recently that was sent here for one of our interventional pulmonologists to put a stent in this left upper lobe bronchus. So a pretty dramatic and severe case of GPA.
Howard, was that I noticed the nasal bones were missing, or at least the internal ones. Was that from the destruction, or was that done to improve drainage or breathing?
I think it's the GPA itself, as far as I know, but I don't have a lot of details about.
And is that
It's terrible, I know. I don't know, Jeff, actually.
Howard, was the 3D stuff at the beginning the same case?
No, a completely different one. So when I saw this one, I was kind of reminded of that patient that I'd seen that I showed you, a different person entirely with a severe ulcerative mucosal GPA.
That was GPA as well, though.
Yes.
Okay.
It was an adult. It presented that way with an acute tracheal GPA. Yeah. Yeah. This one's a really interesting case. So I've shown this one before some years ago from the point of view of findings of tuberculosis. So just quite quickly, she has this upper lobe disease, and this upper lobe abnormality on CT is related to remote tuberculosis. And she's got tremendous parasitism of vessels associated with that pathology in the chest. But I'm not showing that today for the tuberculosis, but rather for her lungs. So let me go back in time and show you this, which is from 2014. And as I scroll through this, ignore that, but just look at the cystic lung disease that will start to appear, but also bronchiectasis. So there is a combination of dilated bronchi, example here, and cystic lung disease. And you can see it's rather extensive in different portions of the lungs, albeit asymmetric, but pretty severe. And I'll show you how severely this has progressed. So I'm bringing over some thin cuts from a recent exam, and I will show you that. So these are back to front, but that's from before, and this is now. And you can see how this has progressed. The bronchiectasis and the cystic lung disease has severely progressed. So let me just bring this up and take a look at that. So in some areas like this, you can see, let me just go up here, how severe the bronchiectasis is. So look at these airways here, really pulled open, and yet they don't have really thick walls. And then tremendously progressive cystic lung disease. And you can see that through the rest of the lungs as well. So this is a person diagnosed with SLE and Sjogren syndrome. So here you can see some information. She was diagnosed back in 2013 with SLE. Here we have a double-stranded DNA test. You can see from 13 and 14 that she has really high levels of SSA and SSB. And you can see she had a transbronchial lung biopsy that showed lymphocytes, but just described as a mild perilymphatic lymphocytic inflammatory infiltrate. And then the last note that I found did describe, as you can see there, dry eyes and dry mouth. So this is a severe case of cystic lung disease and bronchiectasis from Sjogren syndrome. which I ascribe to the protein deposition in the lung producing all these findings, but a very dramatic case of it. As you can see there. Okay, let me show you. This is kind of funny because a couple of weeks ago I showed you a case of a person with lymphoma that developed lymph node enlargement during the course of her therapy. And this is a person with the same kind of thing. So here is a time when new but modest lymph node enlargement appeared in the chest. You can see these are mildly enlarged hilar, infrahilar, intrapulmonary lymph nodes to a modest degree that are big. And a transbronchial biopsy was done at some point showing granulomas. And let me just pick up the last one that I have to look at that. And they are spontaneously regressing, getting better. And this one in this patient was ascribed most likely to interferon therapy. So there is an association between sarcoidosis and interferon. I didn't recall that patients with melanoma or some patients can be treated with interferon. But in this patient, this was ascribed to the interferon therapy. So no lung disease and just modest new intrathoracic lymph node enlargement as a form of sarcoidosis, as you can see there. And it's just spontaneously getting better. I'm not sure if she's still on the interferon or not. Okay, those are my cases, Jeff.
All right, thank you. David, do you have any cases?
I do. Be happy to share.
That would be nice.
Sharing. I tried it once, actually. I found it doesn't really suit my constitution, but I'm going to try again. So here's a man who has polymyositis and has respiratory insufficiency. You can see that he has a tracheostomy tube here because he really can't ventilate very well. And his lung volume is much lower than it was if we go back, say, to 2008. I wanted to show you his CT scans over the years. So let's go back to 2009 here on the right, and you can see that he has decent thickness of the diaphragm muscle down here at the level of the crura. And then in 15, you can see that the crura is very ill-defined. There's some fatty replacement, just as there's fatty replacement in some of his paraspinal muscles back here. So the crus is becoming, the muscle is becoming faint and interspersed with fat. And then on our current exam here, the crus is just almost invisible here. So the diaphragm muscle is really atrophied dramatically with this polymyositis, this muscle disease. And what we see of crus is largely replaced now by fat. So this accompanies his respiratory insufficiency. The other thing is that since he's on a ventilator, he's not using that muscle, and probably disuse of the diaphragm muscle is contributing to the atrophy, not just his underlying disease.
Oh,
So
wow.
let me see let's see if I can pull up the previous case here. Get rid of this. So let me show you this. This person who is a woman who had a kidney transplant in 2000 for polycystic disease of kidneys and liver. And she visited the San Juan Islands off the coast of Washington State. And this is an area that's famous for Cryptococcus gattii, the species that likes the Vancouver, BC area and Washington State and loves the islands. So she came down with this lung nodule. I don't think this was symptomatic, but she did have this nodule. It was CT'd, and it was CT'd. And here's our nodule with some irregularity and some elongation and no cavitation. And this was resected, and it was Cryptococcus, and they identified this as gattii. So at the time this was done, back in 2007, Cryptococcus gattii was still considered a variant of Neoformans. So my teaching file entry calls this Cryptococcus neoformans variant gattii. Now it's been given its own species, so this is gattii. And this was a fairly indolent lung nodule. She was treated successfully, and it's all gone. So those are the two cases I have now. I may be able to get another case for later on, Jeff, if we have time.
Okay. All right, Travis.
I've got some. All right, so main screen, you should see a PDF here. You guys see this?
We do.
Yep.
So this is the one case of hemiazygous continuation I saw as a resident, and we wrote this up as part of a vascular chapter. And it's not as cool as Seth's case, except that we do have a radiograph and then a CT. But this one actually, I think, drained into a left brachiocephalic vein. But it has that similar, like, paralleling of the aorta as it goes up. But you know, it's funny because early on I saw this as a resident and assumed that I'd see more of that. But the one that Seth just showed is the only other one I've ever seen. So they're pretty.
Yeah.
But I wanted to pull that up just to show that it looks very similar to his.
Yeah.
All right, so I've got a bunch of infection cases mostly for Jeff and David, since they're the bug guys here more than anyone. So this is a man who is neutropenic at the time, and I'm going to show this one just because we kind of caught this in evolution, that this is his first CT with his neutropenic fever and just some, you know, few maybe little central lobular nodules. He's breathing, so it's mostly just ground glass, and that was on the 3rd. 5 days later, he now has something going on in his spleen too, and that may be related to that may have been related to his underlying lymphoma or leukemia. But now you can see that we're evolving into this large peripheral area of infarction, and I think this is kind of good. You know, as you guys have kind of termed it before, like a bird's nest appearance. So we were certainly much more worried about fungal infection at this time, and he wasn't getting any better on their regular treatment, you know, just broad spectrum fungal treatment. And then, you know, a few days later, you can see now that it's still evolving this whole rim of hemorrhagic infarction and then multiple other areas. So this eventually did grow out mucor. He grew out mucor in his blood. So this is a case of mucormycosis, which I thought was just nice to show the evolution in this kind of lacy appearance that we see with some of these. So that's. You guys agree that's a good look for mucor?
Yeah, very much. It's a really
that's a classic
yeah.
bird's nest.
Yeah, I was just impressed how quickly it evolved.
It moves fast. They sometimes resect it because if it's isolated because it doesn't clear very well.
So here is another one. We've had a rash of these infections, and this is one that for you guys, this is a new bug that you know, this is another neutropenic patient. I hadn't seen this one before, but certainly you can see some peripheral nodular foci consolidation with halos. Certainly looks and smells like an angioinvasive fungal infection. And this was now the 18th of July in this guy, and you'll see that he was on broad spectrum, including antifungals at that time, and over the course of 8 days got worse. He has worsening consolidation, particularly in the lower lobes. And he was on heavy-duty antibiotics and antifungals in particular. And so a few days after that, this actually grew out another bug, which I had never seen before, which was Cetosporium. So I don't know, have you guys, this is certainly another one of the angioinvasive fungal infections that we occasionally see, but I was talking to the ID people that, you know, that he was on broad spectrum, and it's usually less susceptible, but it is to some of the, you know, the heavy-duty ones that they give, but it tends to be susceptible to voriconazole, so they switched him. And on the most recent one, he was getting a lot more fluid, but some of these nodules had slightly improved, so it seems like he was trending in the correct direction. But yeah, Cetosporium is another one of there's two different species. This is the Apospermum is one of the two that can cause angioinvasive fungal infections from what I've seen.
So
and you couldn't make. Sorry, I was just going to say you couldn't make that diagnosis off the CT. I'm disappointed.
Yeah, I know. Well, I was hoping that Jeff or David could tell me why it is, but
Never heard of that organism before.
Yeah, but
yeah.
there's another name for this, and that's Pseudaloscheria boydii. And we've seen that imitate aspergillus in a number of situations, including allergic bronchopulmonary aspergillosis, where the organism is not actually aspergillus, but instead is Pseudaloscheria. And so
I'm
it seems
glad you can pronounce that because I can't.
Now I know what you're talking about. Before I didn't. Now it's all clear.
so it seems to behave a lot like aspergillus, including the ABPA facet. So if it looks like aspergillus in this case here, I think that's very plausible based on its behavior in other clinical situations.
Right.
Yeah,
So
I've seen
the point of this.
cases to yours, Travis, where it looks like an angioinvasive infection, and then we had one guy who had chronic empyemas because of this bug, and they couldn't eradicate it; they could just kind of suppress it.
Yeah, and I mean, I guess it behaves just like other angioinvasive fungal infections, since that's what it is. It's another natural fungus that you see everywhere. But yeah, the point is when the ID team comes in and tells you, when you say, well, it looks like a fungal infection, they said, yeah, he's growing C. diasporium, then you can just smile and nod like I did because I had no idea what they were talking about at first. But
Wow.
all right.
Okay.
And then you've got this interesting one here. This guy he was a renal transplant a while ago, and this is a long and complicated history, but he had a renal transplant. He came in with pneumonia in his right lower lobe, and they eventually did a biopsy to show the organism, and he refused treatment at the outside hospital, and I'll show you more of it later. But then a couple months later, so this was back in May, he developed right-sided flank pain, and you can see that he's got a little bit of pleural thickening and has this little tail from his lung, I think, into the pleura, and then into this big retroperitoneal, collection, if you will. And so, let's see, I'm trying to figure out what order. And this actually, this was when they were doing a drainage of that. They actually show the pneumonia and the consolidation better. And of course, whenever you have something that looks like it could be contiguous, it's probably more than just coincidence that both things are there. This is the actual chest CT that I saw. And so you see he still has this consolidation with a few small cavities, small effusion, a little bit of pleural thickening, and then this thing that kind of tracks directly into this. So what he actually grew, and this is another collection that's there, this one has been drained in the interim. So he actually grew rhodococcus, which is a gram-positive organism, which has been described frequently in patients that either have HIV or chronic immunosuppression from transplant. And so he had a rhodococcus pneumonia based on an outside culture of his lung. And then when they drained this, that they're not sure if they got gram-positive cocci and rods out of this retroperitoneal stuff, and they're not sure if it's actually enterococcus or rhodococcus, and so they're trying to figure out. But there are a few cases of rhodococcus empyemas, rhodococcus. Let's see, here's the other one, rhodococcus pneumonia in patients that are of various states of immunosuppression. So I don't think I'd actually seen a rhodococcus pneumonia before, but I don't know, Jeff or David, this is another one you can add to your list.
It tends to be a right upper lobe. I've seen 4 cases of this, and I think 3 of them were right upper lobe pneumonias that eventually cavitated.
Yeah, and this paper that had 5 cases of rhodococcus, it was interesting. None of them actually had pleural effusions, but they did have cavitation.
Mm-hmm.
But I think that this did end up necessitating into the pleura and into the retroperitoneum. But they're still not sure if it's actually rhodococcus or enterococcus, but they've got to be related, I would say. So
maybe transdiaphragmatic spread, huh?
Yeah, exactly. And then these are the peritoneal drains. And it may be that they placed it through the pleura when they did the drain check, to show that the contrast was actually in the pleural space. But I think that they're related to each other because he had the pneumonia before he had anything in his retroperitoneum, and he wasn't treated adequately. And now you can see that this is the most recent one that he's been treated and everything's improved. And Jeff, can I show one more really quick?
Sure, of course. Go ahead.
And this, I'm glad that Howard showed the the melanoma sarcoid-like reaction case, because this is one, and I'm going to admit I'm not sure that I buy the diagnosis here or not, but you'll see this is a man who has fibrosing interstitial lung disease, and this is back in 2013. And at this point, it's, you know, it was classified as, this was all outside. He had a possible UIP pattern at that time, so they went to biopsy, confirmed UIP, presumed IPF, and back in 2015, he was started on pirfenidone. And pay attention to the mediastinum here. There's, you know, maybe one lymph node, which we see all the time. But here he was in 2016 in January, and you can see he's got pretty bulky lymphadenopathy throughout his mediastinum, and even down into his upper abdomen. He had some nodes here, portohepatis, and then up in his neck too. He had some supraclavicular nodes, which I don't think we can see on here. These have been getting larger, and so they did a PET, and you'll see that they are very metabolically active. I don't know what the SUV was, but it's legit, and you can see it's all the way into his abdomen as well. So they did an FNA of one of the neck nodes, the cervical nodes, and I think it was this guy, and it was negative. So last month they actually went to excisional biopsy. He's asymptomatic other than his worsening interstitial lung disease, and all they got was non-necrotizing granulomas. And so the question is, because right now they're tentatively calling this a sarcoid-like reaction, but the question is, the only drug that he's on is pirfenidone, and that's never been reported. I don't know, again, I don't know if I buy it yet or not. We're still waiting for some of the cultures. He didn't have any signs of infection, but it's certainly not lymphoma. So it may be another drug that could potentially cause a sarcoid-like reaction.
Or could it
That's
just be
the best
sarcoid?
guess. What'd you say?
Could it just be sarcoid, true, and unrelated?
Yeah, I guess it could be.
Because I think it's possible.
Yeah.
I mean, there's a lot of, you know, emerging evidence that sarcoid is a inhalational lung disease in response to some antigen.
Yeah.
He's kind of old for it, but
I mean,
you see different manifestations in different populations in certain parts.
Yeah, that's fair. I mean, I guess it could be. I don't know.
Not too many things that give you non-caseating granulomas, and sarcoid would give you a really abnormal PET too.
Yeah.
But whether or not it's related to, I mean, I guess if they stopped the pirfenidone, you could see if it went away.
Well, and that's the discussion at this point, and it really complicates things. The reason they were so aggressive in doing the open biopsy is because, you know, this obviously affects his transplant, his transplant eligibility if he had lymphoma or something. So,
right.
I don't know. Well, yeah, I agree with you, Jeff. Though I don't know. It's hard to say. Is it just, you know, are these cases really sarcoid that are just unmasked by some change in the patient's immune status when you start them on a drug?
Yeah, I don't know. I'm trying to remember, but I think back to the pirfenidone trials, I think that there were 3 of them. I don't think a sarcoid reaction was reported in any of them. I'm not 100% on that. But
I couldn't find it.
Yeah, I don't recall that being, you know, diarrhea is kind of the biggest toxicity. It's like 15.
And that's why I'm a little dubious that that's what it is. Like the clinical teams all over this as saying, oh, it's a sarcoid-like reaction. I'm not sure.
So here's the question. If it's not drug-related, do you treat him with, if he's asymptomatic, you probably wouldn't treat him anyway, but, you know, would you want to give him corticosteroids? If so, because that's, of course, been shown to be detrimental to IPF.
Right. I don't know.
Okay.
Seth was going to say something.
Yeah, have you seen anyone actually get better with pirfenidone?
We've seen a couple people that have had their PFTs slightly improve, and others that have stabilized.
Okay.
I think the endpoint for the clinical trials for pirfenidone really, and its approval for marketing, related to diminished progression rather than improvement.
Right. It was they
Right.
used forced vital capacity as the input in the endpoint, and so they showed lower decline or stabilization of FVC. There was a meta-analysis, though, of all 3 trials that was published in the last year that showed actually a 1-year survival benefit at that point. It's pretty small.
Yeah, I was going to ask if there's any survival benefit. 1 year? Okay.
But in the ASCEND-2 trial, which was the last one done that got it FDA approved, there was no survival benefit, and there was really no change in quality of life. It was purely a slower decline of forced vital capacity. But when you
Right.
create the 3 trials, they did see at 1 year small survival benefit. It's pretty.
Yeah, no, that's what the one I remember was that there really wasn't a minimal survival benefit of any, but yeah, no, it's just me being sarcastic because I just don't know how well that drug works.
Yeah, but it's the first drug that showed, or that and nintedanib, first ones that showed anything. So
yeah,
better than previous trials where it was often more detrimental. Okay, I'll show a few, and then we'll have some time. I can go back around. Let's see. Let me load up the first one, and then
If I can show one quickly here that I just as follow up on some of these earlier cases we've seen.
Yeah, here I'll give you control.
So I've got 3 CT scans here in order from 2 CT scans, 1 radiograph here, starting on the right here with April 4th. This is a fellow with Hodgkin's disease who'd had a stem cell transplant, and he has a clear right mid lung. His chest radiograph then, about 2 weeks later, showed a nodule near his right axilla, and he has this very nice aspergilloid-looking lesion here with a dense central component and then a ground glass component around it. So classic aspergillus look. He had some chest wall pain here, so you'd definitely think about something angioinvasive bothering the lung quite a bit. And then just a few days later, here is 10 days later, you can see this thing progress very dramatically. And his CT scan, just showed this huge consolidation here and necrotic center eventually of this big pneumonia. So there was also spread of pneumonia to the other side. So I just wanted to emphasize that a rapidly growing aspergillus-like nodule, you definitely consider mucor as in the earlier case today, but another consideration is Legionella McDadii, which gives you a nodular pneumonia that grows faster than aspergillus but can start out looking just like aspergillus. And that was considered here with the rapid progression. That turned out to be the correct diagnosis here. So this is Legionella McDadii with a fungal-looking nodule initially, but progression that was too rapid. So with the rapid progression, think mucor and McDadii, the 2 M's.
Wow, great. Thank you.
All right, thanks, David. All right, let's see what we got here. All right, so this, can you guys see a chest radiograph?
Yes. Good.
Okay, I got it working. So this was a trauma, a motor vehicle crash. It's a young patient. You can see there's just, a clavicle fracture. We typically don't think too much of these, but he was actually having symptoms. So here's his CT, and you can see you follow the subclavian artery here. You'll see it just stops, and it reconstitutes distally here. And then there's some subcu gas, and then there's the big fracture up here. So they actually went in, and the guy had some extremity issues. So I don't have any intraop photographs or anything, and they didn't do an angiogram. They took him to the OR. Here's the coronals, just showing that subclavian artery is out. And they found it was occluded, so they actually put a bypass graft across that, and then orthopedics came in and fixed it. I've not seen this injury. I mean, we see clavicle fractures left and right, but this was an actual, not even a pseudoaneurysm, but a full-on occlusion of the subclavian artery, presumably from this trauma. And so that was that. Nothing. Just hadn't seen it before. Okay, this case, which I will show the images as soon as it lets me. This was referred to us for evaluate lung nodules on abdominal CT, patient asymptomatic. It's a middle-aged woman who had some vague abdominal pain, nothing exciting. And when I saw this, I kind of knew what it was, and we're not going to biopsy it, but you can see she's got these very small, very poorly defined nodules. Some of them, if I can find one, have almost look like little Cheerios. They have little holes in them. And they have,
Jeff, if you
yeah?
zoom in if you can.
Oh, yeah, sorry. Let's see if I can find some that have the little, you see these little smudgy.
Micro Cheerios.
Little micro Cheerios, yeah, the shriveled up Cheerios.
Yeah.
And they go all the way down, and so they caught a few of these on our abdominal CT here. That's probably what they were seeing. You can see them. They're just very faint in the center. There were a couple of them that looked a little bit nicer. Right here. Here's a nice little one here. So,
And not particularly attenuating. They're all pretty much ground glass attenuating.
but they have very discrete walls, and she's asymptomatic, has no underlying disease. So I had seen a couple cases of this before, of presumptively what this is. I showed it to two of my colleagues who both came up with the same thing without me biasing them. I don't know if anybody else has seen something like this, what they think this might be.
Yep.
I agree with what you're going to say.
Yep. Meningothelial-like nodules.
Yep. Minute meningothelial nodules. Yes. See, once you've seen a case of these, that's what they look like. So, yeah, we're not going to do anything about them because she has no symptoms. But it's interesting. I was digging through the literature a little bit, and people have reported large ones. They've reported them mimicking metastases. I would argue this pattern could potentially mimic like airway spread of adenocarcinoma if you had a lung cancer. But I think once you've seen a case of these, you recognize them. And for some reason, I don't know why they have them. The pathologists see them all the time to the point where they don't even mention them. But we had one case here that got a biopsy for some other reason. I think it was a pre-transplant, so they wanted to know what these were, and that's the first time I'd seen this, and it was just reminiscent of this case. And then there was a case of the day at the STR of this too.
So Jeff, what if there were air trapping along with this? Then you'd think about Dipneck.
Right. Although I have to say, the cases of Dipneck I've seen don't have that many nodules, and the nodules are usually well defined because they're carcinoids. But it is a good point. She was 69. Yeah. She's a good age for it. So, okay.
But you didn't have expiration. You didn't have a test for air trapping.
We were doing it for nodule follow-up. Okay, so this is a cool case that Chris Francois gave me, and I'm not going to, it's the full cardiac MR. I'm not going to go through all the images. He made these beautiful montages. So this is a baby with trisomy 21, and I have 4 images I'm going to show you. So it's just a nice congenital case. So here you see the osteoprimum defect here, the endocardial cushion defect. There's a VSD, an ASD. Notice the thickened RV dilated right atrium. There's also, there is a left aortic arch. You can see there's an aberrant subclavian artery going behind the trachea here. And then we have on these images here, and I'll blow them up so you can see them, move them down. Can everybody see these images?
Good.
The patient also has a patent ductus and aortic coarctation right here. And the aortic coarctation has just been repaired. I think they're still figuring out what to do with the rest. So we've got a bunch of congenital anomalies. And then, let's see if I can find it. They did this without sedation. They just swaddled the baby. But there's also, I think I can see it on here. So yeah, you can see there's the aberrant subclavian artery coming over here. The patient, I'll see if I can find the images that show it, has the portal vein, which is, so it's right here, and maybe I'll make these coronal nips. That's what I'll do. There you go. You can see there's the portal vein. This comes into the IVC as this anomalous vessel, and this is called an Abernathy malformation. It's a type 2 or B or something, where the portal vein drains directly into the IVC, bypassing the liver, and it can be an isolated phenomenon, or it can be associated with other anomalies. I specifically not known, as far as I know, with trisomy, but they sometimes clinically they'll present as teenagers when they start acting odd from the various toxins going from the gut to their brain as opposed to getting metabolized in the liver. They also did some interesting flow sequences using, I just crashed Osirix. Apparently can't handle them. But it just showed, I'll send them along, but it shows the 4D flow, and you can watch it going through the PDA and across the coarctation, as well as the blood coming in from the IVC. But it's a nice example of an endocardial cushion defect with some other congenital anomalies. And I counted the ribs, and the kid had an abnormal number of ribs too, which goes along with trisomy. All right. Well, it's 3 o'clock here, so I think we're done. But thanks for all the great cases.
Thank you.
Thanks, guys.
All right.